So first of all, good morning. I am Attilio Cavezzi. I am a vascular surgeon from Italy. Unfortunately, I don't speak Serbian. I apologize. I guess that you can get some good feeling from Professor Popovic and my experience, but we have to share today. So that's why probably questions are the most important things and discussion during our workshop today. I sincerely thank Professor Popovic because we are here in this very elegant facility and because everything is so technically good, let's say. So my role is just to share with you my experience, especially about foam sclerotherapy, catheter foam sclerotherapy, compression, and so on. And I hope that there will be some questions. And in the afternoon, we will have, after lunch, a couple of clinical cases treated by foam sclerotherapy and the closure remarks by Professor Popovic again. So this is, for me, the first time I am in Serbia, so I'm very, very happy to be here. Well, you can think that I tell everything the same everywhere I go. Okay, but it's really a pleasure for me because I've talked to several friends from Serbia and I wanted to be here, and so I also thank Medi, STD and Medifit because they allowed me to be here with Professor Popovic. So this is honor, but I hope it's useful for everybody to talk about these interesting techniques. As you have heard, laser is interesting, radiofrequency is interesting, surgery is interesting, but as everybody knows, foam sclerotherapy is another weapon we have to treat varicose vein disease. So if you agree, I would go on with the very first presentation. Before treating varicose veins, we have to understand how is the morphology and the hemodynamics of our limb to be treated. I have no special disclosure about my presentation here. So these are varicose veins, and in the past, hands and eyes were used to treat, and the tourniquet, let's say, to treat varicose veins. Luckily, we have today ultrasound. I will show you in those two patients how to use, at least how we use a duplex ultrasound, color duplex ultrasound to make diagnosis. Basically, you can read here how important it is duplex ultrasound to diagnose the condition in varicose vein patient of saphenofemoral junction, saphena magna. I think saphena magna is okay in Serbia because I see that it's well. Okay. Saphena magna, saphena parva, saphenopopliteal junction, perforators, and so on and so on. So duplex is a kind of mandatory tool before tailor our treatment to the patient. Usually we perform duplex in standing position because that's the position where the varicose veins come out, let's say. And I just, well, not recommend, but I would recommend somehow to have a look at these couple of papers where some basic rules were given about the basic principle, how to make duplex ultrasound, and the anatomy, which is the ultrasound anatomy, let's say. So this has been translated in different languages, and you have it also in Russian, if I recall well, in case. And anyway, it is something that, let's say, drives the way we perform duplex ultrasound. So let's start from saphenofemoral junction. In saphenofemoral junction, we know we have a terminal valve. The terminal valve is at the confluence between saphena magna and common femoral vein. And it is very important, as we will see in a second, because terminal valve can be competent or can be incompetent, whatever the condition of saphena magna. So when we perform duplex, basically, I would recommend to perform always a test with the color or with the Doppler or with both on the common femoral vein. If you have a reflux from the common femoral vein through the terminal valve, then you know into the saphena magna, that's saphena magna and this is common femoral vein, then you know that the terminal valve is incompetent because of reflux from the common femoral vein through the saphena magna. And then you have a pre-terminal valve at the level of saphena magna, a few centimeters, 3 to 4 centimeters below the terminal valve. So this is saphenofemoral junction. And it is important to know if the terminal valve is competent or not because of different reasons. This is just an example. Here you can see during Valsalva reflux in safena magna, and that's a typical incompetent safena magna. The same patient, if you put the Doppler inside the common femoral vein, there is no reflux in the common femoral vein. So the terminal valve is competent, safena magna is incompetent. This is a typical condition of early stages of disease, where safena magna may have a reflux, you may get varices, but no reflux from the common femoral vein, which is very favorable for laser, for foam, whatever the treatment. How much is the incidence, the rate of this condition? Well, let's say about 30%. So 30% of your patients with varicose veins and incompetent safena magna have a competent terminal valve. It means that anyhow crossectomy, for those who perform crossectomy, let's say, is not needed because the junction is competent, so you don't need to perform crossectomy. I guess that here in Serbia, as in Italy somehow, you still perform stripping, especially in public hospital. This is the situation a little bit in Italy because of the reimbursement issues. I don't know how it's Serbia, but I think it could be similar, okay? So if you perform any surgical treatment and the terminal valve is competent, there is no reason to perform a crossectomy, let's say. And when the terminal valve is competent, the diameter of the safena magna at the proximal third of the thigh is lower, about 4-5 millimeter at the proximal third of the thigh. When the terminal valve is incompetent, the diameter of the safena magna is larger, for example 6-7 millimeter. This is important because diameter is an issue when we talk about, for example, foam sclerotherapy. The larger the vein, the higher the recanalization rate. That's sclerotherapy, probably also laser and radiofrequency, but that would be a long discussion, let's say. So you see the terminal valve competence incompetence comes around 5 to 6 millimeter as to the diameter of the safena magna at the proximal third of the thigh. Again, you see here there is no reflux from the common femoral vein here and the reflux in safena magna. So the terminal valve is perfectly competent. You see the valve which closes. On the contrary here, you see the safena magna is incompetent, but the reflux comes from the common femoral vein. It means the terminal valve is incompetent. This is physiology. That's how blood goes to the heart. Let's say this is safena magna, this is common femoral vein, these are perforator, this is the junction. This is a typical condition where terminal valve of safena magna is competent, and you have reflux in safena magna because of a pre-terminal valve incompetence and so on and so on. It could be a matter of a pelvic refluxes, it could be a matter of perforator or whatsoever. Anyway, the proximal thigh great saphenous vein diameter, safena magna diameter, is below 6 millimeter. And if you read literature about laser, radiofrequency, glue, the average diameter of the vein which have been treated in literature is around 5.5 millimeter up to 6 millimeter, the average diameter. That means that the vast majority of the patients who were treated worldwide have a terminal valve competence. And that's an easy game, let's say, because we are treating a cat. Here we are treating a lion, which is a little bit more complicated than a cat, let's say. Why? Because here we have a terminal valve incompetence, and the diameter is higher. For example, 6-7 millimeter at the proximal thigh. The junction can be 12, let's say, or 15, but the safena magna can be larger because the terminal valve is incompetent. So you get reflux from the common femoral vein. We are facing a lion. To treat a lion, you need a little bit more strength, let's say. Here we are treating Godzilla. You know Godzilla, probably, the monster, okay? Why? This is the worst scenario. Here you have an iliac femoral valve incompetence or absence. These are the worst patients because of genetics, because of time, because of hemodynamics, because of morphology whatsoever. There could be an absent valve in the iliac segment or femoral segment. As a matter of fact, the reflux comes maybe from cava, maybe from iliac vein, and this is a very complicated case. In fact, the caliber are above 8 millimeter as to the statistics, okay? So these cases are the worst to be treated. Patients have probably the largest diameter, and all treatments may have some problems in terms of recurrence, especially if you leave a stump, such as laser, radiofrequency, and foam. So maybe this is one of the very few cases where maybe crossectomy could be indicated. I don't say it's necessary, absolutely, but let's think about that. So these are different situations for the same saphenofemoral junction. Now we talk about saphena magna. Saphena magna is in a compartment, saphenous fascia, muscular fascia. This is saphena magna. But also saphena parva and other veins are inside the compartment. That's why the eye sign was described, or the Egyptian eye, it was called, where you can recognize immediately what saphena magna is. At the knee level, for example, we described a tibio-gastrocnemius angle. This is saphena magna. This is a tributary. Okay? So anyway, what is outside the compartment is not saphena. That's a tributary. So tributaries are varicose veins. Anytime we see varicose veins, they are not saphena. They are tributaries. In the vast, vast majority of the cases, especially in the thigh or in the upper lower leg, let's say. Because from saphena magna, reflux usually moves to a tributary or to more tributaries, and these are the varices. This is important to recall because varices should not be treated probably as saphena magna in terms of laser, radiofrequency, and so on and so on. How is the anatomomorphology and the hemodynamic situation? In fact, this is a very, very old slide. This is probably 21 years old slide. I published it and I presented it on many occasions. For example, in Sydney at the World Congress of Phlebology in '98. And they told me I am completely crazy because I was very young. So the big bosses worldwide, they told me in Sydney, you are completely crazy. What is this? This does not exist. Well, this is what happens. How many patients have a reflux from the groin to the ankle? Only 3%. But at that time, '98, nearly all surgeons were performing long stripping, which is an abuse, as you see in 97% of our patients, because only 3% have reflux from the groin to the ankle in saphena magna, and the 97% of the patients have reflux in a segment, let's say, of saphena magna. So 21 years ago, 20 years ago, they were telling I'm completely crazy in Sydney. Well, let's say that 15 years ago they started to understand, and 10 years ago they started to accept this is reality, let's say, because saphena magna incompetence is completely incompetent only in very few cases. Now we talk about another saphena, which is called vena saphena accessoria anterioris, anterior accessory saphenous vein. In fact, this is located anterior, lateral to saphena magna, and this vein is responsible of varices in all varicose patients in about 10 to 15% of the varicose patients. So that means that at least 10% of our patients do not need any treatment for safena magna, any treatment for safena parva, any treatment for perforators, but treatment for safena accessoria anterioris, which is located over the femoral vessel at the proximal third of the thigh, where it lies, in fact. It is lateral to safena magna. And it's not easy to recognize if you don't check for the alignment sign. The alignment sign permits you to see the vein exactly over the femoral vessel. That's not safena magna, that's vena safena accessoria anterioris. For example, reflux from the junction through the terminal valve, but reflux goes to the anterior accessory saphenous vein, not to safena magna, which is healthy and has no reflux, in fact. And you can see here on the skin, this is safena magna, which is normal. This is safena accessoria anterioris and tributaris. So again, duplex permits you to treat the proper vein and to treat the proper segment and so on and so on. Let's come to the worst vein, safena parva. Why is it the worst vein? Because of complications, because of recurrence. It is by far the worst, let's say. But in fact, if you know anatomy and hemodynamics, and duplex helps, you can treat it. Which are the problems of safena parva? First problem, hemodynamics. Again, when you have incompetence of safena parva, the terminal valve is competent in more than 50% of the cases. So, whatever the situation in safena parva, reflux, terminal valve is competent in more than 50% of the cases. It means do not perform crossectomy because the terminal valve is normal, as you see. And this was published long time ago, but vascular surgeons and phlebologists never read it or never believed it was true, because anytime you see safena parva incompetence, at that time or even 20 years ago or 15 years ago, always crossectomy, which is completely wrong, because there is no need to perform crossectomy if you have reflux in safena parva, but no reflux at the saphenopopliteal junction. Again, there are cases of reflux also in popliteal junction, of course. As you can see, this is the minority of the cases, but, and this is the typical incompetence of safena parva, competent at the level of the popliteal vein. No reflux from the popliteal vein. But there is another issue. Can you go forward? Next slide.
Just a second, please.
Okay. Because there is another issue which complicates things, let's say. The other issue is anatomy, morphology. We should be back, probably. Okay. Yes, okay. Morphology, wow, sorry. Morphology is a problem because, unfortunately, about, yeah, here we are, about, can you go just to the next one? About 25%, 30%, 25% of safena parva does not go straight forward to the popliteal vein, but merges, for example, the gastrocnemial vein. Vene gastrocnemiae, okay? So that means that there is no sapheno-popliteal junction, but sapheno-gastrocnemial popliteal junction. And again, what to do if you perform crossectomy? We have to discuss. There are many cases without sapheno-popliteal junction. I tell you a very nice story, and then we go ahead. A big professor from Italy, I will never tell you the name, a big professor in Italy performed a live workshop. So surgery of safena parva, I was very young, there were maybe 300 people in the hall, it was in the operation theater, He did not perform any duplex because he was a big professor, he didn't need. He opened popliteal, looked for the junction, there was no junction. And then he said, okay, see you later, and closed the TV link. So you could not see anything because he could not find the saphenopopliteal junction because there was no saphenopopliteal junction. The reflux was coming from the pelvis, probably in that case. Duplex is mandatory to understand how is the situation. That big professor looked for 1 hour the junction and could not find any junction because there was no junction. It is important to know if you have or if you haven't a junction to the popliteal vein, for example. Okay, Saphena parva can also connect to Saphena magna via Giacomini vein, or can directly access the gluteal area, the pelvic area, through the thigh extension of Saphena parva. So it can go to Saphena magna, Giacomini vein, or it can go directly to the pelvis or to the thigh through perforators or connection to the upper part, and that's called thigh extension of Saphena parva. Let's go to the end of the presentation. We have perforators. Perforators are not so important when we talk about varicose veins, primary varicose veins, because the vast majority of the perforators are in the lower leg and they are re-entry perforators, which means that when you try to detect the bidirectional flow in the perforator, bidirectional flow, you get incompetent perforator, but it is very, very important to understand how is the net flow. Everybody knows that the bidirectional flow means that you compress, release, and you see one direction and another direction. That's incompetence. Okay, but in the re-entry lower leg perforators, okay, the majority of flow is inward, which means you compress the distal part and you get some little reflux, but when you release, the majority of the blood comes into the deep veins through the perforator. That's a typical, let's say, bidirectional flow perforator, but with a prevalent and physiologic re-entry flow. So you should never treat re-entry perforators because they are normal perforators which drain. I don't want to make things complicated, but this is what, again, many, many years ago was published by Jordal. Jordal was a very nice Norwegian pediatric surgeon, from Norwegia, pediatric surgeon. Long time ago, 71, he published this elegant study where he clearly demonstrated that in primary varicose veins, the perforators have a prevalent, I would say, absolutely prevalent inward flow and a very tiny outward flow during systole. Contraction is outward, during relaxation is inward, which is normal. So Jordal told, please do not care of the re-entry perforators in the lower leg. But he was a simple Norwegian pediatric surgeon. And Frank Cockett from UK was the boss at that time. Frank Cockett destroyed Jordal, but Jordal was right and Cockett was wrong. But you know, Frank Cockett was the big boss from UK. How can you obstacle Frank Cockett? It's impossible. So Jordal was defeated, but he was right. And today we know that perforators are completely innocent conduit to have a re-entry flow in primary varicose veins, not in post-thrombotic syndrome and so on and so on. This is a typical condition of a very large perforator, 4 to 5 millimeter in the gastrocnemius area. As you can see, during contraction you have outward flow, but during relaxation a very nice inward normal flow. It's a bidirectional flow, but again physiology is respected for the vast majority of the flow. So what does it mean? It means that basically even a very large perforator should not be touched, because after stripping, after laser, after radiofrequency, after foam, the perforator shrinks and becomes normal, because it was dilated because of the re-entry flow, not because of pathology. And that's why long time ago, 98, as you can see here, I presented again in Sydney these findings, and they again told me I was completely crazy, but today it has been accepted, luckily. Going to the hand, we have pelvis, and pelvis can be a problem, because from pelvis we may get refluxes, and we may get problems to the patient which has varicose veins, but the reflux comes from the roof, not from the leg. So you should fix somehow the roof because of all these refluxes. And probably one of the most important vein in this case is the left ovarian vein, which is very often incompetent, and that's the issue. Okay, and you can see here a kind of rain from the pelvis through the lower limbs. Whatever you do in the lower limb, it may be affected by the refluxes from the pelvis. Foam is the only treatment, everybody knows. No chance to use laser or radiofrequency in the veins which are around the vagina, around the buttock, and so on and so on. Recurrence. Recurrence, unfortunately, is a problem, and it is probably around 20 to 30% at 5 years. This is what science tells us. About 20 to 30% of the patients have reflux after 5 years, whatever the treatment. This has been demonstrated in different studies. This is another consensus document which I would recommend. Maybe we can give some files, if you want, at the end of the workshop to all the participants about these documents if you have not the documents. So you have to study with duplex. You see one case or two cases here without any relevant reflux at the stump. So the patient was operated well at crossectomy side, but the patients get reflux from vagina and from the vascular, let's say, varicose net at the groin. So notwithstanding a good operation, maybe pelvic refluxes, recurrence, neovascularization, or whatsoever. In this case, the patient was not operated well. They left a stump, very long stump, and through the anterior accessory saphenous vein, you get recurrent varices. So whatever the choice, you have to know what to do in recurrences, and duplex helps to know what to do. Sometimes you have just tiny groin neovascularization, and foam again is the only hope you have to treat these veins. And as you can read in different papers, such as this one from Marianne de Mesner and myself, about 30% is the recurrence rate from laser radiofrequency at 5 to 6 years, for example. So duplex, at the end of the day, permits you to draw a map. You draw a map for the great saphenous, anterior saphenous, Giacomini, thigh extension, saphena parva, and so on and so on. And after the mapping, then you can tailor your treatment through foam, laser, radiofrequency, phlebectomy, and so on and so on. No duplex, no party, let's say. So we have to play the game thanks to the duplex. Otherwise, we may get more recurrence, more failure, more complication, and so on and so on. Thank you. Hvala. That was my first presentation, but of course we need questions, not just talking only. So if there are questions, they can be translated into Serbian, of course.
So, still no questions. Niko nema pitanja? Za sada? Nema pitanja? It was just perfectly understood, I would say, Dr. Cavezzi.
I
Thank
think
you
that
very much.
we will have a lot of time for discussion today. So, if you want, we can continue with your next presentation, and after all, we will see.
Okay.
Next 10 hours we will be together.
Okay.
I think there is a lot of chance for.
Okay. So my next presentation, we start to enter in foam sclerotherapy. So we can go.
Or even maybe we have some questions.
Okay. If you have
Just go
Okay.
ahead. Yes, please.
So now we start to speak about foam. And foam, as you know, is not a very new treatment, but not a very old treatment, because it started probably in 97 officially. But everybody knows from history, well, I will not talk about history of foam because it would take a lot of time, that the foam started probably in the 30s, in the 40s, in a kind of primitive way. But they started to say, well, foam could be better than liquid, and that was 60 or 70 years ago. Then slowly, through the Spanish, Cabrera especially, and then Monfrey, we started to think, through their very, very preliminary reports, that foam could improve sclerotherapy results. Why should foam be better than liquid? Okay, I have no special disclosure here again. Foam is better because probably you get a better final concentration of the sclerosant into the vein. It means that when you use liquid, unfortunately you don't get the concentration in the vein which you wish, but you get the proper concentration in the syringe, which is not what you wish at the end of the day. In fact, sclerosant foam can be produced only with detergent drugs, as Richard showed you previously. For example, from STS, Fibroven, you get foam as well from polydocanol. Other drugs such as iodine solution, sodium salicylate, chromatic glycerin, and so on cannot be transformed into foam because they have no soapy constitution, let's say. When you inject liquid, you get, let's say, 3% STS in the syringe, then you may get a very, very relevant dilution in the vein because of blood. And as we will see, it's not only a matter of dilution, it's also a matter of neutralization. We will see in a while. So liquid is good, probably only, or let's say better even, only for minor varicosities, telangiectasias, reticular varices. I will not speak about that because that's not the topic of this symposium today, but we can discuss about minor varicosities as well. When you inject foam, very likely the concentration you have in your syringe is the concentration you have in the vein, at least in close proximity of the entrance point of the needle. Because then you have some blood here, and so you can get some problems at a distance from the injection point. But anyway, foam is able to displace blood in proximity of the entrance point. So the active final concentration is more easily reached at the end of the day. This slide is so old. This is 21 years old. I took this slide in 97, so it's not very well taken probably. But you can see I was starting my sclerosant foam experience, 97, November. I was afraid because I was one of the very few in the world to start, and I was calling I was calling Alessandro Frullini in 97 because we were the very first in Italy to start. And I told Alessandro, did you kill anyone? No, everybody's alive still. Okay, so let's go ahead. So that's the very beginning. Because when we started in Italy, there were 2. In France, there were 2. In Spain, there were 2 probably. That's all. No one else in the world. 6 people in the world were trying foam. And this is one of my very first patients. And I took this picture. Why? Because when I injected liquid, that was my current practice at that time, the usual practice at that time, when you inject liquid, the liquid goes and that's it. I was injecting foam in this patient who had the popliteal fossa perforator incompetence and varices, and the foam was still there after 5 minutes after the injection. And I was shocked. What is it? That was the vein with the foam inside. And I was shocked. I never saw this before in my life, because liquid enters and that's it. So foam was stagnating in the vein. And I immediately started to think it should work much more than liquid, because liquid goes away, foam stays there. So it works, in fact, more than liquid. That's why I present this slide, because it was the very beginning of foam in the world, let's say, and I was starting in '97 with a lot of fear, as you can imagine, and that was the syringe, the glass syringe foam, so that was Monfreux technique. Then in '99, Lorenzo Tessari came, and everything changed because of the plastic syringes, of course. So there are a few basic rules when you perform foam sclerotherapy. Let's try to examine some of them. For example, we need small bubbles. That's the secret. The smaller the bubbles of foam, the higher the active surface of foam, the smaller the residual empty space among bubbles. So we don't love large bubbles. We want small bubbles to get a better foam, more effective and safer foam. Because anyway, if you have smaller bubbles, you also have probably a longer duration at the end of the day. You don't need a 10 minutes lasting foam, of course, but you need at least for 1 minute a good foam, let's say, to be injected. Okay. So let's try to get a good foam. Why do I say this? Because anyway, foam depends on us. How do we perform foam? Which material? And unfortunately, it's not a completely standardized procedure. How do we perform foam sclerotherapy? Well, the vast majority of the phlebologists perform it under ultrasound guidance, for example, or under visual guidance. When you treat safena magna, safena parva, the ultrasound guidance helps you to cannulate the vein, aspiration of blood, injection of foam. I would recommend always to aspirate and see blood before injecting foam, especially in the larger veins, because that gives you the insurance, let's say, that you are in the vein. Otherwise, you can inject without aspiration of blood, which is not something I recommend. It should be a very experienced doctor, let's say, to do this. This is another very, very old slide. You see 2000. It is March 2000. And this is safena magna. This is, I would say, the very beginning of Tessari foam, because Lorenzo called me one night, it was 11 o'clock in the night, and he screamed me at the phone, "Attilio, I got another method." Say, "Hey, come on, Lorenzo, what the hell are you saying?" Well, anyway, he discovered another method. He sent me the tape. There was no internet. Well, there was internet, but Lorenzo was not that good. So I received the tape, and I saw the tape on the video, on the TV. I said, and called Lorenzo back the following day, "Lorenzo, go to Paris and show it to the world, because this is very interesting." And this is Tessari method, the very preliminary experience, the saphenous vein with the foam inside, the preliminary spasm, and 110 days after results. This is a very good result. And as you see, this is a very good result after 110 days. Not all patients go so well, but that was one of the preliminary experience with Tessari foam, let's say. And this is the same patients 110 days after foam sclerotherapy. When you treat safena parva, duplex guidance, I would say, is mandatory. Why? Because safena parva in this area is full of nerves and arteries. This is an issue, full of nerves and arteries. So never inject nerves and artery, and you see the vein and you inject safena parva. Again, aspiration of blood and then injection. And as you see, you can inject also far from the popliteal fossa, because foam anyway goes upwards without any problem. You don't need to inject exactly at the popliteal fossa, because it is more dangerous and less effective at the end. Another very, very old slide, 99, with Monfreux foam, the very early foam, let's say. which has been abandoned, but I was using that foam at the beginning. You see Safena parva, the needle inside, and the foam after some 10 minutes probably. And this is again 10 minutes after the injection. You see the spasm and the foam inside. That was 99. When you treat tributaries, when you treat varices, in the vast majority of the cases you don't need duplex guidance because they are usually visible, palpable, so you can cannulate the vein directly through a syringe and a needle. And this is what you can perform. I mean, you fill the veins, as you can see here, and filling the veins permits you to remove somehow blood from the veins, which is very, very important. Because as we will see in the next presentations, the tributaries and the veins in general, when they have too much blood, they deteriorate sclerosant liquid or sclerosant foam. That's why we should try to remove, let's say, blood. Okay, how do we treat perforators with foam? Foam is a very, very good treatment for perforators. You see here a post-thrombotic limb. This post-thrombotic limb has different perforators, several perforators which are incompetent. That's a typical situation in post-thrombotic syndrome. And generally speaking, the bidirectional flow is evident, and during relaxation, the perforators has reflux, not re-entry, as it was the case in primary varicose veins. So, having said this, foam is the best treatment, but everybody should know that perforators in post-thrombotic syndrome tend to recur very easily. Glovitsky is a very, very famous vascular surgeon. John Bergan, another very, very famous American vascular surgeon, they wanted to spread SEPS technique. But after a few years, they told everybody it doesn't work in post-thrombotic syndrome because perforators recur, but they recur because in the deep veins you have a lot of problem, hypertension. So where can blood go if it's not going well into the deep veins? It will go through perforators in the superficial vein, and it means that the perforators reopen, recanalize, or new perforators come. Anyway, foam is so cheap, so easy, so quick that you can do it anytime you want on the perforators to help ulcers to be healed and so on and so on. Never inject the perforators, but inject the varices. The varices in proximity of the perforator can be treated, possibly with an elevated limb, as I try to do most of the times when I treat varices. And if you inject directly, because foam will go from the varicose veins directly into the perforator without any problem. If you inject the perforator, you have two problems. It's dangerous because unfortunately any perforating vein has nerves and especially artery, satellite artery. So instead of injecting perforator, you may inject the artery. So first problem. Second problem with danger is that foam injected into the perforator immediately goes in the deep veins. And so it's dangerous. But if foam goes out of the perforator, it means it's not effective anyway. It's not efficacious anyway. So never inject the perforator. Always inject the varicose veins in proximity of the perforator, and foam will enter the perforator with less risk, let's say. Along the time, different people started to use different material to inject foam. So basically, what I will show, of course, after the coffee break will be after this presentation, yeah? Yes. Okay. So different material means cannula, different material means catheter. Why? Probably one of the guilty, let's say, is Cabrera, And the other guilty ones, not guilty, I apologize, are Bradbury and Coleridge-Smith, because the Anglo-Saxon technique and the Cabrera technique is based on cannula, which is good, because you put the cannula in, fix it, and then you do whatever you want because it's in the vein. You prepare your foam and give your foam and so on and so on. And that's very interesting, of course. I prefer catheter, as I will tell you later, but cannula is something you can think about if you are not that good in cannulating the vein through a syringe or a needle, which I prefer. But okay, you can use a needle and a syringe, or you can use a cannula, or you can use a butterfly. Butterfly is not so well indicated because of the long tube and silicone, so you get some disruption of the bubble because of silicone, as Richard showed you before. Anyway, different material is to be used as per your preference, let's say. How can we work? Let's start from mapping. This is the way I work, let's say, but I give you just ideas. Proper position of the patient. I prefer to raise the limb prior to the cannulation and injection. This means it is more difficult, I know, because if you raise the limb a bit, the vein shrinks. But that means less blood, and that helps. Elevation or not, then you have to choose the proper needle, length and caliber, the proper drug, and the proper concentration. For larger veins, I prefer 1 to 3% STS, because polydocanol, as Richard showed you, is a little bit weaker, nearly half the power of STS. Foam formation, of course, we have Tessari method. I will show you slight variation, but I will tell you later. And then you have injection. Well, I suggest you inject within 30 to 40 seconds maximum, if you use air, which I don't like, but you can use air. If you use biocompatible gases, such as CO2 or CO2O2, then you have even less time. I will show you in a while, okay? So you inject your foam, and then you check what's happening in the vein. For example, you can see that part of the targeted vein is filled, and then you decide to re-inject the vein, for example, 15 centimeters below the first injection site, for example. It depends on the cylinder of foam which is created into the vein. It's a kind of white string that you see, and then you target the second injection. So you reform your foam, which is very easy with the Tessari method, and you re-inject. How much at the end of the session? That's something to be discussed. If you use air, let's say that the Anglo-Saxons suggest up to 15 milliliter per session. This is not a let's say guideline, this is a recommendation, but there is no cutoff, there is no agreement, everybody has his own method. Let's say someone said, no, not more than 8 milliliter, such as the French, they say 8 to 10, the Italians, as usual, compromise, 12 milliliter, and the Anglo-Saxon, 15 milliliter. Well, I would say with air, up to 15 milliliter per session, but you can decide on your experience. I like to put some drug, some zinc oxide or other similar creams, cotton and pads, and then compression, strictly medi. Okay, I'm joking because anyone has his preferred stocking, but okay, remember the need to compress properly, which means stockings mostly, in a few very selective cases, bandages when you perform foam sclerotherapy. I prefer stockings because bandages, we will discuss a little bit, loses pressures in 24 hours more than 50% of pressure, so it's a very complicated issue. So volumes per puncture, per injection. This is the European Consensus Conference here, where we published for example, per injection from 2 to 4 milliliter when you treat larger veins. And when you treat smaller veins, it's completely another story. Again, I don't speak about smaller veins, but let's keep in mind that when you treat smaller veins such as telangiectasia or reticular varices, You don't need to kill a lion. You don't need to kill Godzilla. You need to kill an ant. So just use very soft technique, soft dose, soft concentration to get proper results, because it's a cosmetic issue. It's not a functional issue. So you see less than 0.5 milliliter. I would say around 0.2 milliliter for telangiectasia of liquid fibrovein, if you like. 0.1%. Richard will not be happy about 0.1% because they want 0.2, but 0.1 could be
Dilute with saline, it's fine.
diluting with saline. For reticular viruses, if you use STS, you can use 0.2 up to 0.5. Well, again, I'm using lower concentration to be on the safer side because it's a cosmetic issue. So you want a result, but more than a result, you don't want side effects when you treat cosmetic issues, okay? That's why I'm trying to get less and less, fewer and fewer side effects through lower concentration. And you see here different concentration according to the consensus conference, European Consensus Conference. Higher concentration, of course, for safena magna, safena parva, and recurrence, and for example, venous malformation. I know Professor Popovich is also expert in venous malformation. And if you use foam, you can use 1% STS, 2%, but even 3%, I would say, it's sometimes used when you treat venous malformation, especially when they are deep, let's say. So there is a learning curve. I don't know how many of you perform foam sclerotherapy currently. Maybe it could be interesting to know. I mean, if 50%, 80%, or 100%.
Yes.
I don't know in Serbia how is the situation.
Very few.
Very
Very
few in
few.
Serbia at the moment. Okay, so whatever your experience, 0 or 100%, you need a learning curve if you are starting. And you have to know, or better, your patients have to know that maybe 10, 20, 30% of your patients need retreatment at 5 years. It's scary. Dentistry. We are dentists. We are stomatologs, okay? Why? Because carie and chronic venous disease and varicose vein disease are very similar. So I treat you today here, tomorrow I treat you here. It means your patient must know treatment is forever. That's why we love to be phlebologists and they love this kind of disease, because the disease is forever. And the patients must know it, and so you retreat the patient. If you don't treat your tooth, the carie spreads. If you don't treat your vein, the disease spreads. That's why you put your clock backwise with sclerotherapy, with radiofrequency, with glue, with foam, with anything you use, laser. You put your clock backwise, and the clock starts again. That's what I tell my patient, and they like it. Okay, I know, doctor. You do what you can, and then I'll be back in 3, 5, 10 years. And that's what happens. We must be very honest to our patients. Otherwise, their expectations are too high, and that's a problem. Then you need to optimize the way to prepare foam and injection. Good indication. Foam is not for any vein. Foam is for the majority of the veins probably, but probably not for any vein, not for telangiectasia. I do not recommend foam for telangiectasia, and not probably when you have a big, big Godzilla vein, let's say 20 millimeter vein in the thigh, or 15, 20, I would prefer stripping. I still perform stripping in 2 to 3% of my patients, not more, maybe 2%. But it depends on my patient. When patient comes with large varices and especially large stem, which means again 15, 20 millimeters safena magna and 30, 40 millimeters saphenofemoral junction, I still think that we are vascular surgeons, we are surgeons, we must open the groin, perform crossectomy and stripping. 1 to 2% of my patients at the moment. The rest is for foam, phlebectomy. I will show you my experience. So I don't know how is the situation again in Serbia. You still perform probably a lot of surgery as in Italy in public hospitals, as I told. I think that surgery should be indicated in very, very large vein. I mean stripping. Phlebectomy is completely another issue. When you treat only tributaries, okay, that's wonderful. But if you have to open the groin, to open the popliteal fossa, you should do it only in very selective cases. That's my humble opinion, let's say, because we have endovenous treatments today. Then you should use different measures to help foam sclerotherapy, such as elevation of the limb, but especially immobilization. I want to tell you one thing, not because I'm an expert, but because I had the luck to be in more than 20 countries teaching foam sclerotherapy, more than 20 countries, but especially being in the hospitals, being in the offices. And I see very, very different foams, very different measures, and especially I see very different, behaviors. So one very bad and wrong behavior is to inject the patient and then start to move the patient, the limb, foam, stand up, go. Completely wrong. Immobilization of the patient after foam sclerotherapy. It's important. 5 to 10 minutes immobilization. That helps to maintain foam into the vein, to avoid too much foam into the deep vein, to reduce nearly at zero any relevant problem in the heart, in the lungs, in the brain, because foam must stagnate exactly in the target veins, not in the deep veins. It goes in the deep veins, but if the patient moves, if the patient laughs, if the patient sings, there is a lot of foam entering the deep veins. So the patient must be silent, quiet limb, quiet patient, and everything goes well. I tell you because on the contrary, I see a lot of different things worldwide, and that's not very good, let's say. Well, I prefer physiologic gases, but that's an issue I don't want to stress too much. I will discuss probably in a while. I try to keep the time. Okay, there are variables. Let's talk about the variables in foam formation, which is not a standardized procedure, as I told you. Drugs, gas or air, ratio, material. I wanted to study. I never published too much about these studies because I never had the time, because I'm a bit in troubles with publications. I have never time to do it, but there are many, many variables, and material is important. So we studied under the microscope what happens according to the material, for example. So let's go ahead for a second. So I performed a study under the microscopy. You see the setting or the material I wanted to test. Let's have a look. When you use STS fiber vein, the average, this is one study from Lorenz, okay, there are many other studies, but the average radius of each bubble after 60 seconds is around 33 micron, and you have larger bubbles when you use polydocanol because they are different. Polydocanol has a higher, how can I call it, cohesive power, which does not permit the bubble to break after some time, and the bubble tend to become larger, which is not exactly what we want, the large bubbles. We don't want large bubbles, and that happens more with polydocanol. So STS foam bubbles are smaller, and this is nice because I told you the smaller the bubble, the better the outcomes, for example. And they have a lower duration, which can be good or bad according to the time you need to inject. But anyway, the bubble tends to break a little bit earlier than polydocanol. And at the end of the day, for safety, it's of course better. When you use physiologic gases, CO2 or O2, duration is much shorter. This is important to remember because air contains nitrogen, and that's a safety issue somehow, but especially that helps to have a slightly, or let's say a quite longer lasting foam. Let's talk about one important variable: syringes. Again, being in 20 different countries and in 50 different centers, hospital, offices where I was in my life, I saw so many different syringes. And 90%, 95% of the syringes are simply rubbish for foam formation. Sorry to tell that, but especially I was very, very often in Holland, and they use so many different syringes, but they get a very, very bad foam. Then I get out my, Buffalo Bill, you know, get out my syringes and prepare my foam and look and say, what is it? And we never saw this foam. I'm not good. Syringes are good. So you need proper syringes to prepare foam. Look at this slide. If you use, just for example, discarded BD, but discarded 5 milliliter and Terumo, which was the very early experience we had, you get smaller bubbles. And this is important, smaller bubbles. The other syringes give you larger bubbles. The traditional BD, the traditional brown, whatever traditional means silicone, means lower duration, means smaller bubbles. Needles. If you use, let's say, 23 or 25 gauge needle, the blue and the orange needle, to inject foam, your bubbles will have a good diameter at 30 seconds. If you use smaller needles, such as 27 or 30 gauge, the bubbles will be disrupted and foam will be more liquid. Okay, let's move on. Okay, this is gas. Very quickly, I don't want to stress too much this point. When you use physiological gases, such as CO2, you see the bubbles are smaller after 10 seconds and smaller after 60 seconds. But more than that, the bubbles have a very, very low standard deviation, which means are much more similar, much more coherent than the air bubble. The air foam, unfortunately, has a larger bubble. Fortunately, has a longer duration. Good and bad, okay? So I prefer, for safety issue, the CO2 or whatsoever. Well, during my experience with foam, after 3-4 years, let's say 2002, 2003, I started to use a couple of tricks to make foam better, let's say more consistent, smaller bubbles, higher duration, and so on and so on. How can you do that? Very simple tricks and tips. One, you should rotate a little bit the three-way valve, let's say 20, 10, 20, 30 degrees, so to narrow the hole inside the three-way valve. And you get, as you can see here, a smaller bubble. If you don't rotate, you have larger bubbles. First little tip and trick. Second tip and trick, let's say, is the contra-resistance method. I will show you the contra-resistance method live because it's not easy to explain, but it means one of the two syringes should oppose a resistance so that you get smaller bubbles, as you see here, and you get longer duration. Hard to explain theoretically, very easy to explain practically. To get a better shaving foam, similar to the shaving foam. Again, when you use bad syringes, the half liquid time, you can call it half-life, okay, is much shorter with traditional syringes, 63 seconds. When you use proper syringes, the half liquid time is much longer. You have more time to inject your foam. That's why, for example, my Watkins gave me this slide, but Richard showed better slides, and you will give me, Richard, okay, those better slides. Anyway, Mike Watkins gave me maybe 10 years ago this very nice slide. This is a typical syringe everybody uses worldwide. This is Terumo syringe. Here is the same time. You see large, dangerous bubble, ineffective bubble, you see no bubbles, and so much more effective on the right. This is Terumo. This is one of the 100 different syringes I see everywhere in the world which are wrong, simply wrong to make foam. Adjuvant measure, we are moving quickly to the end of this second presentation. You can elevate the limb. You should immobilize your patient. Let's tell one thing. Stockings. We are here in the reign of stockings. Never put stockings for a minimum of 5 to 10 minutes. Why? We hate Valsalva maneuvers after foam sclerotherapy. Because Valsalva maneuver, as everybody knows, blocks the blood flow and then release. That's Valsalva. And when you put a stocking on, it's a perfect Valsalva. So, what does Valsalva maneuver mean? First, a bolus of foam which enters the deep veins when you release, which we don't want, we don't like. Second, we will see when we talk about complication that the patent foramen ovale can be an issue. Well, not so important. And how do you dilate, how do you enlarge the patent foramen ovale to know if it exists? With Valsalva maneuver. So if you perform a Valsalva maneuver putting the stocking on, you open your patent foramen ovale, which we don't want. So never put the stocking for the first 5 to 10 minutes. And if you put the stocking, the nurse or you should put the stocking, not the patient. So you avoid the Valsalva maneuver to the patient. Stupid things to say, but very, very important measures to reduce side effects and complications. So, elevation of the limb prior to the treatment. That's a possibility. You reduce the caliber of the vein prior to the cannulation. Everybody tells me, okay, we put the cannula without elevating the limb, and then we elevate the limb. That's okay. That's absolutely okay. It's what, for example, Anglo-Saxons do, Cabrera does, and so on and so on. And that's something interesting. To put the cannula, even in standing, the Germans do it in standing sometimes, put the cannula, the butterfly whatsoever, or the needle even. That's SIG technique with a lot of blood on the, on the ground, but okay. And then you elevate the limb. So you reduce the size of the vein. You can see here the tributary standing, the tributary in the elevated position, the saphena magna in supine, the same saphena magna in elevated position. You reduce the caliber, you reduce the blood, you probably increase the efficacy. Compression, we will discuss about compression later, of course, but I want to tell immediately a couple of things. I don't want to go too far. Compression is stockings, compression is bandaging, but compression is Laplace law. The pressure we give to the limb or to the area depends on the tension, directly proportional, but also depends, and it is inverse proportional, to the radius of the area we treat. So if we can decrease the radius, everybody would agree that we increase the pressure with the same tension. Stocking has a prefixed tension, because stocking is stocking. Bandaging, you can variate, but stocking is a fixed, permanent, for a few months, let's say, tension. So you get always the same pressure according to the radius of the area you treat. If you put pads, you can change the radius, and so you can increase the pressure, maintaining the same tension. This is a little trick to increase the pressure. Let's have a look at what Ugo Parch showed. Ugo Parch is a very, very, very famous guy in the world. I would say the most famous in the world for compression. He's a kind of great friend for me. You see here that with this kind of pad, this is a stupid example, you can nearly close the saphenous vein, which is not possible without any pad, for example. And you see here the difference in terms of pressure and how to occlude the great saphenous vein at the thigh level, which is nearly impossible, as we know. So you can use, for example, Struva, you can use Medivan, but I always prefer to combine with cotton, as you see here, to change the radius and so on and so on. Here you see after Safena Parva treatment. So again, let's go into the hand. Why do I like CO2 or CO2 plus O2? Because they give you, these gases give you more safety. Probably you see here a study where the scotomas and visual disturbances were decreased thanks to the CO2 or O2. At the end of the day, foam sclerotherapy is effective, especially when we treat slightly smaller veins. Look at this very elegant study from Philip Coleridge-Smith. He treated saphenous vein of about 5 millimeter, 6 millimeter, and the final results are very, very good, as you can see here. 88% occlusion after 1 year, about, and this is another slide from Philip. He gave me this slide, which is very nice, just foam sclerotherapy in this case. But when we treat smaller varices, we know that we may get some problems. This is video capillaroscopy. After foam sclerotherapy, we may get some necrosis. That's why this is the very early experience we had with foam sclerotherapy in telangiectasia. That's why in minor varicosities, we do not recommend in the vast majority of the cases foam sclerotherapy. This can be a case where foam sclerotherapy could be indicated because it's a matting, huge telangiectatic matting. Maybe foam can be indicated. So if you stick somehow, if you stick to the European guidelines or recommendation, you can read a lot of things about contraindication. I would love to talk about this maybe in the following presentations, but again, the contraindications to foam sclerotherapy are the ones from sclerotherapy, plus could be an issue the patent foramen ovale, if we know it, because here, today we are maybe 35, 40 people, I don't know. There are nearly 10 people who have a patent for foramen ovale, maybe me and you, who knows? But it's a very small one. So the problem is the symptomatic patent for foramen ovale. Otherwise, we know that it's not an issue in the great majority of the patients. The relative contraindications, again, we know. Let's have a look in the next presentation to the thromboembolic risk due to thrombophilia. Thrombophilia is something we should discuss later on because sometimes we may discover prior to foam sclerotherapy treatment. So foam in the end has advantages, we know. We may need lower doses, we may need lower concentration. We see what we do, but especially foam is more efficacious, more effective than liquid, and it is an extremely cheap treatment. Let's remember we are talking about 5 to 10 euro treatment in comparison to 200, 300 euros with the traditional laser, radiofrequency, whatsoever. Unfortunately, some disadvantages, for example, suboptimal standardization as to foam formation, material to be used, and so on and so on. A few side effects or complications have been described. I would say that in clinical practice they are not that important, but we will see during my presentation. And at the end of the day, what we do, even after 6 years, we have reduced the capacity, the compliance of the vein with foam sclerotherapy. So even if in presence of recanalization, a 9 millimeter vein, which is 1 millimeter with some reflux, could not be an issue. No symptoms, no varices. So recanalization is an issue for sclerotherapy. It depends if it gets some symptoms and some varices or not. That's why sclerotherapy is easily repeatable and is very interesting for all of us, especially foam sclerotherapy for the larger veins. Thank you. Hvala again. And I'm just punctual. Questions would be nice to get. But
okay, I will invite everyone to I think that you opened so many fields for us, and I would like to say Professor Cavezzi, because you learned us a lot. I will now ask a couple questions, but maybe I will later on some other from the Auditorium wants make some question?
Any questions for now? Pitanja za sada.
Okay, you know, how long you leave this compression on the extremities after starting therapy?
Yeah, we will discuss about compression, and I will say there is no agreement, there is no consensus, because there is no consensus. We know that the first 2-3 days are probably the most important as per George Fagan's experience. The sclerothrombus formation is important, especially in the first 2-3 days. So anyway, for a minimum of 2-3 days, I would say for a minimum of 2-3 weeks, I would recommend some compression. The very first days, the very first 5, 6, 7 days are very, very important. So let's say class 2 stocking, minimum of 7 days. I prefer class 1 or class 2 stocking, talking about foam sclerotherapy, for a minimum of 20-30 days, because anyway it reduces side effects. And Italian patients are very demanding, very challenging. You can get good outcomes, but I have some pain, I have this, I have that. So if you want to reduce side effects, science tells you compression helps. As to efficacy, we don't know, but as to side effects, we do know that anyway compression helps for a minimum of a few weeks, let's say. There is no consensus.
Thank you. And one more question from me. Do you have any data how long this foam formation stands into the day? How long? You show us 5 minutes, but do you have any data?
No, yes, of course. I mean, if you use air, luckily or unluckily, nitrogen stays in the bubble for a longer time. If you use biocompatible gases, CO2 or O2 go out of the envelope, the bubbles shrink and breaks and so on and so on. So there may be bubbles even for 1 day circulating in the blood or in our body, let's say. What we know, what I will show, is that probably the chemical action of the bubble is neutralized in few seconds when it touches blood. So the mechanical action of the bubble could be an issue for some minutes, because whatever we see in the heart when we make, for example, echocardiography, is the white spots. That's not necessarily the bubbles, that's the interface we create through the bubbles. So I have no data to tell you. Let's say that for a few minutes the bubbles stay there with some chemical action if there is no blood. If there is blood, chemical action is reduced more and more. The mechanical issue is an issue, but we know that the bubbles disrupt anyway, especially with the biocompatible gases. So I have no numbers to give you, because it depends on many things. If you perform Valsalva, don't perform Valsalva, which drug, which gas, which movement. So there are many variables.